It's 5 o'clock, so I think we can get started with this webinar. So, dear Professor Bartfay, board members, and dear guests, it is my pleasure to host today's webinar. First of all, I would like to thank Drs. Boris Ata and Csaba Pribensky for accepting my invitation to give their presentations today. Being an infertility specialist, I chose IVF-related topics. Now, in vitro fertilization has an almost 45-year-old history if we date it back to the birth of Louis Brown. And over these past 4 decades, almost all of the steps of in vitro fertilization have undergone major improvements. In the 80s, stimulation was introduced into the practice of IVF that resulted in the recruitment of multiple eggs and the creation of multiple embryos, often the transfer of multiple embryos, and we had to start dealing with multiple pregnancies and other complications like ovarian hyperstimulation syndrome. Nowadays, we say that the IVF treatment is successful if a full-term healthy singleton is born, and the twin pregnancy or a multiple gestation is often considered as a complication of in vitro fertilization. So we somehow have to balance our practice because we would like to increase the success rates as much as we can, but we also would like to keep the multiple pregnancy rates as low as we can. So this is the biggest challenge because the overall success rate of in vitro fertilization has not risen as much as we were all hoping for. We can say that there's still about 25 to 30% live birth rates per embryo transfer. We often achieve this with the transfer of not just one embryo, but 2 or even 3 embryos. So the biggest challenge is to identify the embryo to be transferred that has the highest chance to implant. And over the past 2 decades, genetic testing, time-lapse monitoring, proteomic or metabolomic testing of spent culture medium have been explored to see if these can be used in clinical practice. And pre-implantation genetic testing and time-lapse monitoring have remained with us, and we are using these technologies these technologies are used worldwide. Still, the most common technique of embryo selection is selection based on morphology. But I hope to hear from the 2 presenters today what is it that the technologies that they will talk about can add to this. We will start today's sessions with Dr. Boris Ata's presentation. He will talk about pre-implantation genetic testing. Dr. Boris Ata graduated from the Istanbul School of Medicine in 1998. He did his OBGYN residency and then completed a subspecialty training in reproductive endocrinology and infertility at McGill University in Montreal, Canada. He graduated with an award for excellence in gynecological reproductive endocrinology and infertility. He is a clinical researcher with a master's degree in clinical trials from the London School of Hygiene and Tropical Medicine. He has published over 130 peer-reviewed papers on various aspects of female infertility. He has served and serves on the editorial boards of Human Reproduction Update, Journal of Obstetrics and Gynecology of Canada. He's an executive committee member of ESHRE. He's the president of the Turkish Society of Reproductive Medicine. He works at ART fertility clinics in Dubai and in Koç University, where he's the chairperson of the Department of OBGYN. And in addition to his scientific achievements, he has received multiple awards for his research, education, and quality of patient care. So Boris Ata, I'll give this virtual floor over to you, and we look forward to your presentation.
Dear board members, dear colleagues, I'm really honored for the invitation. I'm a bit excited. Thank you for the nice introduction, and I'll start right away for the sake of time. So can you see my screen?
Yes, we can.
Wonderful. Okay. So Yeah, the subject is pre-implantation genetic testing for aneuploidy. So this will be a clinically oriented talk. I won't get into, much technical details, but, please feel free to ask or discuss, after the presentation. So these are my disclosures. None of them are relevant for the presentation. It's all my own opinions. So, aneuploidy is the major problem in human reproduction. It's reflected by decline in spontaneous fertility, fecundity with age, and increased risk of miscarriage by increasing female age, and which both of which are due to aneuploidies in the embryo, which is also reflected in multiple studies over different centers and different years. As we can see, most of the blastocysts that are generated in the IVF lab have aneuploidies, and with increasing resolution of the test we've been using in the last 10 years, so the euploidy rate it almost keeps coming down as we improve our vision on the chromosomes, and it is linearly associated with female age as reflected in spontaneous fertility. So shortly, PGTA, which is pre-implantation genetic testing for aneuploidy, is an embryo selection tool. So in this example, you see 5 blastocysts that have been developed in the lab, and assume the ones with red inner cell masses are aneuploid, and the other 2 with green inner cell masses are euploid, which we don't know without the test. Okay, so in morphology of the embryo does not allow us to know which one is euploid or aneuploid. So what we're trying to do is, with testing, it's not treatment, it's a test. With testing, we're trying to actually identify the euploid embryos and prioritize them for embryo transfer to reach live birth in a shorter time and with a lower number of transfer cycles. That's what is intended to do. And it is a pretty complex intervention. It's a multi-step complex intervention which requires blastocyst culture, then a trophectoderm biopsy to provide DNA for analysis. And since it takes time to have the results, we have to vitrify embryos. And then with one of the available platforms, we perform comprehensive chromosomal screening. And if the embryo is aneuploid, so we won't be transferring that embryo. The idea is to find the euploid ones, if there are any, and then form that embryo and transfer. You see, it has many steps, which most of which are, if not all, operator dependent and have some variation. In life, nothing works 100% effectively. Okay, so we can't claim trophectoderm biopsy is not harmful at all. So there might be some small margin. Okay, we can't claim that the testing technology we use today is 100% accurate. It may be close to, but wouldn't be 100%. Nothing works like that in life. And after the introduction of vitrification, embryo cryopreservation has improved tremendously, but still survival rate is not 100%. It may be close to 99, but 100%. So as such, with some attrition in each step, you may expect some harm, right? So maybe if you just keep transferring every available blastocyst until they're exhausted, one by one with several cycles, in theory you would have a higher cumulative live birth rate unless other complications arise. So the reason I'm saying this is, this is a test that aims to prioritize embryos for transfer. Okay, so we shouldn't expect it to improve cumulative live birth rate. Okay, maybe that may be only possible maybe through decreasing patient dropouts and maybe decreasing costs, which I'll explain slightly later. Okay, so having said that, I don't really want to get into too much detail of the published randomized controlled trials comparing embryo selection by PGTA or by morphology, mostly with different platforms in different populations. So far as I know, 7 of them have been published. 1 of them is recently published in the New England Journal. As you see, except for the ESTEEM, the Ashraf on the trial, they all used trophectoderm, and the EV study, they used blastomas. I mean, the current standard of care is trophectoderm biopsy and next generation screening. So the studies do not show an improvement in cumulative live birth rates. However, they are defined. We can discuss the limitations of each study, but as I explained, the concept, that shouldn't be the expectation to start with. And I'd like to, briefly remind the principles of diagnostic testing, and PGT is not any exception. So, as no test is 100% accurate, the accuracy and actually the positive predictive values and negative predictive values of any test would depend on the prevalence of the sought for condition aneuploid in the context in the tested population. That's another fact to keep in mind. So with that principle, you would expect to see a beneficial effect of PGTA among women who have a high risk of aneuploidy. So in this chart, I show euploid rates. So aneuploid rate would be here like 68%, here 82%. So after a certain age, it keeps linearly increasing, but after a certain age, probably around like 38, 39, almost 3/4 of the embryos, and in advanced ages, almost 4/5 of embryos are aneuploid. So now, what is the current ART paradigm? So what are we trying to do nowadays, and how do we measure our effectiveness? So this shows, this is for ovarian stimulation, the first step of ART. Then we do the egg collection, we do the embryo culture. So we can do a fresh transfer right away, and we can freeze any supernumerary blastocyst. Then if the possibilities are the patient can be pregnant or not pregnant. If she delivers, it's fine. If she has a miscarriage, she may either drop out without trying further treatment, or she may continue with frozen embryo transfers from this cycle until they're exhausted if she doesn't have a live birth. Okay. So with this improvement in vitrification technology, there are new concepts, there are new parameters for success, which is cumulative live birth rate per stimulation cycle, or even family completion rate. I mean, if a couple wants 2 or 3 children, okay, per stimulation cycle. And now with this effectiveness, we are concerned about, other measures like time to delivery or cost per child. Okay, so, and how, if obviously a test would not improve the cumulative live birth rate per cycle because it doesn't fix aneuploid embryos, but how can it be beneficial? So where can it have a positive impact? As Peter said at the beginning, in the past we were transferring more than one embryo, which caused an epidemic of multiple pregnancies and all the associated complications. Okay, so knowledge of the euploid status of the embryo may facilitate acceptance of elective single embryo transfers for the patients and the clinicians. That's for one. And secondly, no matter how much in detail we explain to the couples in advance and try to adjust their expectations about, not all the good-looking embryos have normal genetic content and they're not necessarily competent. Okay, so after every failed cycle at any age, I mean, failure can be not having a pregnancy or a miscarriage. So they would still ask you why it failed. And then, when you make all these explanations about, anticipated euploid rates, anticipated, euploid implantation and miscarriage rates, etc. So still, it's a psychological stress. It's difficult for them to grasp the concept. And then some of them, just drop out of treatment, even though, they have insurance coverage or even though they still have the means to do it. Okay. So by providing them knowledge about, why it failed, it may, in theory, I would say, decrease dropouts. And by selecting euploid embryos and prioritizing them for transfer, it may, when used properly, decrease time to delivery, decrease the number of transfer cycles to reach live birth, and depending on the context, I'll explain a bit later, decrease the cost per child. So let's see if it is possible. So these theoretical advantages may come at a cost, except for in addition to the financial aspect. The risk of PGTA is, as you see, you can test. And we've always been concerned about the test wrongfully showing an euploid embryo that would have a decent chance at live birth, the test can show it erroneously as aneuploid or abnormal, and that embryo can be discarded, and this may decrease the chance, the probability of cumulative live birth rate. So that was the major concern. So there are studies looking at, in discarded embryos, looking at, agreement between, trophectoderm biopsies and inner cell mass, cells from inner cell mass. But I mean, they are in vitro studies. I think the most valuable ones are these studies with clinical data. The one I'm showing is from EVRMA, New Jersey. So what they did, I think this is a landmark study, to see if PGTA was able to deselect aneuploid embryos that wouldn't have a reasonable chance of live birth. What they did is, in a clinical setting, they biopsied, they took trophectoderm biopsies from all the blastocysts. They didn't test them, and they just proceeded with embryo transfer based on their morphological criteria. And then when the cohort was completed, they went back to analyze the trophectoderm biopsies and compare the results between women who had a live birth and who did not. Okay, and what they've seen in this sample, which included actually more than 300 live births, and more than 300 euploid embryos and 102 aneuploid embryos, what they saw was none of these 102 aneuploid embryos that have been transferred blindfoldedly reached live birth. Okay, some of them implanted, some of them became clinical pregnancies, but all at the end ended in failure or miscarriage. So obviously, with one study, you can't decide that it's 100% accurate in determining aneuploid embryos that wouldn't reach live birth, but it's the best available data. So based on the confidence interval, you would expect that harm to be maybe like somewhere between 0 to 2.4%. So this study has been recently published, and we've already written a letter for that. So this is coming from New York, and what they did was this group has always been an anti-PGTA opinion, which is they're right and they have their reasons. And patients who have been treated in other centers and who underwent PGTA and who were told that their embryos were abnormal and shouldn't be transferred, and they didn't have any euploid embryos, they carried their embryos to this center in New York, and they, after consenting properly, they transferred these embryos. And what they write in the title and what they claim is, with abnormal PGTA results, the embryos that were previously denied transfer have some chance of live birth, and they reported, overall, I think, 8 live births. But in detail, what happened is the embryos that they call abnormal were diagnosed as either full chromosomal abnormalities, or diagnosed as mosaics, which I'll get into more detail soon, or diagnosed with segmental aneuploidies. Okay, and of the 102 embryos you can see in these red lines, which had been diagnosed with full chromosomal abnormalities for 1 or more than 2 chromosomes, only one of them reached live birth. Okay, all the others live births were from embryos that were diagnosed as putatively mosaic or segmental aneuploids. Okay, so remember the other study, again, similar number of aneuploid embryos transferred, 0 live birth, and here there's only 1 live birth, so which comes to 0.94%. Okay. So I think the expression, the use of the term abnormal here is inaccurate. They should have been called mosaics or segmentals, and yes, as they suggest, they shouldn't have been excluded from transfer cohort. But this is already been known since 2016. Okay, so what is mosaicism? I mean, there's one reason that I put a line on the name is presence of more than one chromosomal distinct cell line in a single sample from an individual. Okay, in the context of embryo, what you would expect, what with real true biological mosaicism, some of the cells would have, let's say, a normal euploid line in trophectoderm and inner cell mass, while some others would have aneuploidies. Okay, so that would be called an euploid-aneuploid mosaic. Okay. So does this really happen, or how often does it happen? So true mosaicism would be reflected after birth as confined placental mosaicism or fetal mosaicism, or could be case of uniparental disomy. Okay. But what we're doing here with PGTA, so this is the embryo, assume this is the mosaic embryo. So we take few cells, so the embryo, and there's an expanded blastocyst, has about almost 200 cells. What we do is, we take 3 to 10 trophectoderm cells, which would be a combination. Then we degrade all these cells. We don't test them one by one, and pool their DNA content. Okay, so we don't see different cells really, and we amplify them to be able to analyze. Then looking at their fragments, tagging them, and trying to understand to which chromosome they belong with complex bioinformatic methods, we try to decide how many copies of each chromosome is present. So that's an approximation. Okay, in an euploid embryo, in this graph, each column is a chromosome, and on the y-axis, you see the copy numbers. So an euploid embryo would have two copies of each chromosome. You see 2 here, and that's what you would see. And this would be missing an X, and would have a Y, since this is a male. If in the case of monosomy for a chromosome, you would see 1 copy of that chromosome, or in the case of a trisomy for a chromosome, you would see 3 copies. Okay, if it's a mosaic, you would expect to see a number that is different than 1, 2, or 3, because in your DNA mixture, let's say it's an euploid-aneuploid mosaic, some cells would bring DNA that has 2 copies, and some cells would bring DNA that has 1 copy. Let's say it's a euploid and monosomic mosaic. Then overall, you would have a copy number somewhere between close to maybe 1.5, depending on how mosaic it is. All right. So it is not a diagnosis of true mosaicism. It's not by looking at different cells, but it is by deduction, ascribing the different copy number than 1, 2, or 3 to biological mosaicism. Okay, so but it is only one of the possible explanations. Okay, so most of them are probably test artifacts, which I'll explain soon. And since 2016, from the first position statement of the Pre-Implantation Genetic Diagnosis International Society, it was already suggested that these embryos would have a chance of live birth, and they could be transferred. A SRM committee opinion also said the same. And this is one of my favorite editorials by Richard Paulson. So, and they shouldn't be called mosaics. Maybe we should better call them the embryos with intermediate copy numbers for 1 or more chromosomes. Okay. And this has been actually proven with real life data. This was published last year, coming from the US, and this is data from more than 1,000 embryos that have been transferred, despite observation of this intermediate copy numbers. Okay. And they're compared with over 5,000 embryos that have been transferred after being diagnosed as euploid. Okay, so what it shows is obviously euploids on the left-hand side had the highest chance of live birth, followed by low segmental aneuploidies, then high segmental, low 1 chromosome segmental, low 2 chromosome, and then mosaics. Okay, so depending on the extent of abnormal copy numbers you have, you can prioritize them. And furthermore, what they showed is, so in the upper box, you see euploids. And then in the lower box on the right, you see those segmentals and mosaics. Depending on their morphologic criteria, trophectoderm, inner cell mass, or expansion stage, embryos with better morphology which have been diagnosed with putatively mosaicism or segmental aneuploidies may actually had higher chance of live birth as compared to embryos that have been diagnosed as euploid but had worse morphological characteristics. So that shows it's probably not true segmental aneuploidy or true mosaicism. And based on this data, you can prioritize embryos, euploids for transfer. Euploids would be the first, followed by embryos that have been diagnosed with low segmental aneuploidies, low whole chromosome, mosaicism, then high segmental, etc. Okay, so the paper by Barat and colleagues was published after this anyways, and the transfers have been done after 2016. So it was already known that mosaics and segmental aneuploids, as diagnosed with PGTA, had a chance of live birth and they shouldn't have been denied transfer in the first place. So it's not the test itself, it's how the results were reported and interpreted at the original centers, due to some understandable concerns, but against society guidelines, let's say. Now, again, back to the effect of prevalence on the positive predictive value of a test. So far, in the literature, there are more than 2,000 mosaic embryo transfers that has been reported, but there's only one case that has been confirmed to exist postnatally, similar mosaicism that had been diagnosed with PGTA, and that's from Semra Kahraman's team in Istanbul. So that also attests to the fact that the positive predictive value of the segmental aneuploidies and mosaicism is really very low, because the underlying prevalence of true mosaicism is really low, or segmental aneuploidy is really low, and most are probably test artifacts in one of those steps, as I mentioned before. So that brings me to the point that when we're talking about PGTA, it's not uniform. Okay? So it depends on how it is done. So again, Scott's team have shown nicely the results may be affected by two main facts. I'll get into more detail about trophectoderm biopsy probably in the next slide, but the amount of the handling medium in the goblet where you put the trophectoderm biopsy even affects the DNA amount. And then the software you use, its resolution, also affects the results you observe. So it is highly, it's highly operator and equipment dependent. So I would say not all the PGTA is the same. Every center should, monitor their own results and see. Now, the effect of trophectoderm biopsy. So this was presented as an oral presentation in ESHRE annual meeting 2020. This is from Spain, Barnaby Clinic. What they did is, in many cases, laser is used for trophectoderm biopsy. And as you cut through the cells, through the confluent trophectoderm cells, there may be some damage to the cells. And they categorized their trophectoderm biopsy samples based on the amount of cell damage. So grade 1 was with no damage, grade 2 little damage, let's say grade 3 some more damage, grade 4 more than half of the cells were damaged, probably by laser. Because I mean if you've seen how laser is used for biopsy, you see the red dot, then there's a shot. But yes, the center of the shot where the beam is reaches the highest heat, but it disseminates around to smaller degrees. Probably it even affects where you place the laser shots, and even as compared with just cutting through with laser, then making a small opening with laser, and then just trimming the cells, which they called flicking, may affect the rate of this uncertain diagnosis of mosaicism. You see, euploid rate was the lowest in the biopsy samples with the most cell damage. Okay, and the putative mosaicism diagnosis rate was the highest in in the group with the high cell damage. So which means they're bringing these bits and pieces of DNA, and the biopsy method again affected the rate of mosaicism you observe in your test results. So to me, these are really convincing evidence that it depends on operator and technology in many steps. So this is in publication. This will be presented in this upcoming ASHA annual meeting as an oral presentation. So this compares the rate of mosaicism from different centers with different embryologists, and as you see, there's a fluctuation. Okay, in the full data, it actually changed between almost 2.9 and 23%. Okay. And it's not only mosaicism, even the diagnosis of euploidy changes between different centers. So this is reprogenetics data from US, from I think it was from maybe like close to 20 centers sending their samples to reprogenetics. You see some centers and small centers with small volumes have been excluded from this analysis. So even centers with high volume, you see there's a difference, which may be due to underlying populations, but these are adjusted for age. Okay. And again, I just like to emphasize one more point. So in the past, with the former version of PGT, with the former biopsy technique, when we used to just collect blastomeres from a day 3 embryo, which had 6 to 8 cells, it was later shown that it affected the embryo. Okay, now it's commonly said that trophectoderm biopsy does not harm. Okay, so it comes from 2 publications by Scott's team. Okay, but as this is operator dependent, so I don't think everyone can claim that the way I do biopsy is as good as in EVRMA New Jersey that has a huge load and huge experience. Okay? So it's a microsurgical procedure in a sense, and it would be operator dependent. Everyone should follow their own data. So my conclusions as a clinician is it is a operator dependent multi-step complex procedure. Okay, but given the data published by Scott and even Bharat, it seems it accurately identifies blastocyst with full chromosome aneuploidy, with the risk of blastocyst vestige being less than 1%. Okay, all other embryos are transferable with different priority that would limit a theoretical adverse effect on trophectoderm biopsy and all the other test artifacts on chances of cumulative live birth rate. Okay, and even though we don't expect a test to fix the embryos and make the aneuploids deployed, still in couples with high prevalence of aneuploidy, most simply women of advanced reproductive age, PGTA, by deselecting embryos with full chromosome aneuploidy, which could be as high as 70% at those ages, would undoubtedly prevent fetal transfers and would decrease the risk of miscarriage, okay, in resulting in pregnancies resulting from aneuploid embryos. And miscarriage is not only a time and cost issue; it may have impact on endometrial lining. It is associated with some risk of adhesions and endometrial trauma. And as we're talking about, like women at the towards the older age, time is really important for these people. Okay. Another thing that has changed my mind about PGT over the time, because I was much more critical in the past, is we know most of the failure is due to aneuploidy. Okay, and this there's this vague definition of recurrent implantation failure, which is a made-up diagnosis in a way. And it could be used to define populations with other problems. It may be useful to define people maybe who would give up further treatment, or it may help you to diagnose other pathologies. After you exclude failure due to aneuploidy, the most common reason. Okay, so based on this published euploidy rates, which has been more or less stable in the studies I've shown over the last 10 years. And based on, again, the reported live birth rate per euploid embryo transfer, if we start transferring, untested blastocysts, even in the young group under age of 35, the cumulative probability of implantation or live birth would reach, like 80%, or from a strict statistical point to 95%, only after transfer of 6 blastocysts. And maybe then you can tell someone, listen, if your only problem was embryo aneuploidy, you would have been pregnant and you would have a live birth by now. So maybe there's another rare problem which we can't diagnose today, which we can't treat today, and you may consider other options, or they will comprise the best population for further research. Okay, but you can't make this deduction, this claim, for older women. Let's say for someone who is at the age of 41, 42, to reach a live birth chance of 80%, if the only problem is aneuploidy, they would need maybe 8 or 9 blastocyst, untested blastocyst transfers, which would take probably several cycles with these women, as they would have decreased ovarian reserve as well. So the knowledge of euploid status actually gives very important information for counseling. Okay, and this is a study by Paul Pirtea, which shows actually if you transfer 3 euploid embryos sequentially to a patient, almost 90-95% of them will have a live birth after 3 blastocysts. Depending on based the euploid live birth rates, this figure may vary between 3 to 4, but that shows us again convincingly, that real life data shows us again convincingly, most of the time it's the embryo. And if we will do any studies about endometrium, systemic factors, etc., we should first rule out embryo aneuploidy to have meaningful research. Okay, so the other concern, now that I think I can say, at least I'm personally convinced that it's accurate, it's an accurate test to diagnose full chromosome aneuploidies, then what I'm risking, okay, so the risk of embryo vestige is small, then it becomes a cost issue. Remember, I said in theory, by preventing fetal transfers and other pregnancy complications that would end without a live birth anyways, it may help save money, which can be used for future treatments. Right? So cost effectiveness studies depend on a lot of assumptions. Right? So the study from US showed, where they did in-house PGT with $50 per embryo cost, it would be cost effective even after 1 blastocyst. Whereas the Italian study, where the test costs almost 300 euros per embryo, it only becomes cost effective after maybe 4 blastocysts and in different ages. Okay, so this should be calculated at the own setting to see if it's cost effective, but I would say it is mostly depends on how much the cost of a frozen embryo transfer cycle is. Okay, so this is my second conclusion, and the generalizability of any trials, any studies should be critically analyzed with looking into detail of the techniques, the equipment, prior publications, etc. And I think we shouldn't have a fixed opinion as anything in science, okay? And inform couples properly based on their age and anticipated euploid rates, discuss with them, advantages and disadvantages of the test, and, make a joint decision. So I would say, PGTA would be useful for older women who have a high prevalence of aneuploidy. And especially if, rarely that older women have high ovarian reserve, which would yield, several embryos to choose from. So that's where the test would be most useful. Okay, people with different reproductive histories, with recurrent pregnancy losses, recurrent failures, etc., may be more likely to have aneuploids. But I mean, it's not established. And again, if it's being paid out of pocket, I think, and based on the costs on the local setting, finances would be an issue as well. But biologically, older women with high ovarian reserve would benefit. And that discussion, that open discussion with the couple is, just fits into the definition of evidence-based medicine. Okay, so I'd like to thank you for your attention. I hope I didn't, exceed the time too much, and looking forward to any comments, questions. or after
much.
however specific.
You have not exceeded the time at all. I actually would like to give a chance to Csaba Pribenski to give his presentation, and then we will still have time for questions in the end. So the second presentation is by Dr. Csaba Pribenski. He graduated at the University of Veterinary Sciences in Budapest, Hungary, and he earned a PhD degree at the same department. Currently, he's a senior research fellow, a lecturer, and an associate professor at the University of Veterinary Sciences in Budapest, Hungary. And he's a senior scientist at Vitrolife, Sweden. He has multiple research interests. One of them is studying the impact of controlled stress to improve cell performance. And the other one is live cell imaging for evaluation, decision support, and quality control, which involves time-lapse monitoring. Dr. Pribenski has published over 40 peer-reviewed scientific papers. He held hundreds of presentations at various conferences, and he has 5 patents to his name. Some of them are granted, some of them are pending. So, Csaba, we are looking forward to your presentation.
Thank you so much, Peter, for the introduction. Can you hear me well, and can you see the screen?
The screen, not I can hear you. I don't see the screen yet.
Okay, then it's on my system, it's okay. Could you please tell me when? Can you see that now?
I see the IDA score presentation.
That will be the second one. Okay, this is it. What can you see, Peter?
It's completely black. Yeah. For a second, I saw the picture with the mountains.
Yeah, that's supposed to be it.
Okay.
No, it's a black screen. No, okay. Oh.
Is it okay now?
It comes up temporarily. Now we can see it.
Okay.
Foreseeing the fate of an embryo.
Okay, that's it. Thank you so much. I guess the speed of the internet is not that fine here. So basically, I got the task from the organizers that I should discuss the time-lapse imaging of embryos and how that can be used for evaluating the embryos and selecting the embryos. And I would like to split my talk into 2 parts. One would be a general introduction to time-lapse and what are the basics and who are the pioneers and what it can be used for. And the second one I would like to discuss when AI comes into the picture. So let's start. Time-lapse is basically used for embryo evaluation. We would like to evaluate the embryo. We would like to know what is happening inside of the incubator. And of course, we have 2 things to choose. We would like to get a lot of information from the embryos. It means that you need to open the incubator door quite often, and we need to take them out quite often. But that would be a compromise on their quality. And the second is that if we want to get a lot of information, then we would need to take a lot of images, a lot of movement, a lot of embryo manipulation. This is not really good. So how can we deal with this balance? Let's say that you take your embryo out from the incubator and you see this image. You would not be happy to transfer this embryo. If you see this image, you would not be happy either. But what if this comes into your hands? This is a very, very nice blastocyst. Are these different embryos, or there is some connection between them? Basically, this is just an example. There is a phenomenon of blastocyst pulsation. It depends when you take the embryo out from the incubator. You can have an image which is quite nasty, but you can have an image which is quite nice. And based on that, you may bring a completely different decision, and you would transfer this embryo if it looks nice, but like 20 minutes before that embryo would have been a nasty one. You would maybe discard it. Without a time lapse, without taking a lot of images, without taking a lot of samples from embryo development, you would not be able to bring that decision, right? So basically, time-lapse, as it is used, it is the tool to select the best embryo for transfer. All of these basically to support elective single embryo transfer. So time-lapse is a tool to perform embryo evaluation without embryo handling. Time-lapse is a digital solution. It archives all moments of embryo development. So it is it's an excellent tool for quality control and quality assurance as well. And we've been using it for communication between the embryologist and the gynecologist, and also the gynecologist can show the proper embryo development to the patients when they communicate which embryo to transfer, what are the options, and what happened during the cycle. So this is really basic, and let us discuss what is the classic approach to evaluate time-lapse information. What are the principles? We know that time-lapse is giving us morphokinetic data, so we use that morphokinetic data, but we also need to use our established knowledge of morphology. Quite a few years, more than a decade have passed, so we have convinced that there is no golden parameter to look at. There is a combination of quality markers from the first cleavage until the brustulation and expansion, which counts actually. And then you have to add on the top of it embryo morphology, the classic one. And the combination of these quality markers can give you a proper estimation of the chance of the embryo. There are quite a few important events to consider, right? Timing of the 2-cell stage, 5-cell stage, timing of the brustulation. Of course, there are other measures like the length of the different interphases and cleavage cycles. So these are definitely measured by time-lapse. Then we are adding blastocyst morphology, and of course, we are adding fragmentation as well. So these are those dynamic events which actually do count when we would like to tell the fate of the embryo. Again, in the classic old school era, what we've been doing, we were manually annotating the embryonic events. And of course, there are softwares helping this work. And based on many research and many data, there are reference values which offer the time corresponding to the given event. And based on that, we can really define if those special events belonging to that embryo are falling into those reference values, then those embryos should have a higher chance for implantation. If they're outliers, then they have a lower chance for implantation. Of course, the embryos, they modify or improve the rank based on those morphokinetic events, based on the way how the embryo looks actually. This is the old school way: manual annotation, reference value set from literature, customized by the clinic. This is what gives a good chance for telling the difference between the embryos. Let's just go through fast some science behind the time-lapse selection, time-lapse evaluation. One of the most important things, everybody likes to talk about this one, is the actual cleavage timings and interface timings. The embryo needs to cleave. The cytokinesis is a fast procedure and supposed to be synchronized. And then in between two cytokinetic cycles, there's supposed to be a long preparation phase, which is called the interface. So interface is supposed to be long, defined. The time frame is defined based on which is that interface, and then the cleavage is supposed to be fast and synchronized like this. So if the embryo is performing that type of rhythm, then we can have a good estimation of a good embryonic quality. These have been researched decades ago by early devices. The first device, which was like an inverted microscope and an environmental cask set around the microscope, and that setup was able to follow up embryo development until the 2-cell stage, which was not really good, but the first data was provided by this setup. The second combination was that a proper environmental box plus a stage-top incubator, and the combination of these two devices would support embryo development until the 4-cell stage. So that's the first landmark publication by Dr. Mio from Japan, who described the first 4 cleavages and tried to connect it to relate it to embryo embryo development to the blastocyst stage. The next one, which we have to definitely mention, is Dr. Lemmem. This paper has been referred to many times. She also could follow up embryo development at the 4-cell stage and could see that what are those events that were relevant for the pregnancy outcome and for the non-pregnant outcome. And there were the synchrony in the appearance of the nuclei in the 2-cell stage embryo, which were somewhat significant. But if you see the number of data and if you see the overlap, this is also just a publication which shows that there is something in this technique. But again, the technology at that time was not there to support a proper embryo development until the blastocyst stage. The next publication was actually presenting a tool, a compressed digitally inverted microscope that is put into your existing incubator. And this was the first tool which actually provided an uncompromised development, an uncompromised follow-up of embryo development up until the blastocyst stage or even the hash blastocyst stage. So this publication was showing the device itself, and this was a mouse embryo data showing that the first 3 cleavage cycles they predict blastocyst formation in vitro. Also, this was the first publication which said that actually fragmentations are reversible, and the average time a fragment is present is 9 hours, which means that if you take every second day embryo evaluation, then you are going to miss most of the fragmentations, which actually tells you that the embryo there's something wrong going on with the embryo. So you should be able to see that. The first paper and the first timeless baby, basically, where timeless was used to select a single embryo on day 5 based on morphokinetic events. That was published 12 years ago, and that guy was born. The name of the guy is Attila. He's in 6th grade already. So this is the first time that baby was actually published 12 years ago, and I guess it's quite an important publication, at least for us, showing the first step in a long journey. Definitely need to mention Connie Wong's publication in Nature Biotechnology. They were also focusing on the first cleavage events. The duration of the first mitosis, it's supposed to be less than half an hour. Again, mitosis, the cytokinesis, it's a fast event. And the timing between the first and the second cytokinesis, that's supposed to be in between 8 to 14 hours, which is also important that there has to be a long preparation phase before the next cytokinetic event is happening. And also they described that the direct cleavage events, when the cell is cleaving from 1 to 3 cells directly, which is a definitely negative sign. In their publication, the endpoint was blastocyst formation. They were using cryopreserved embryos, so there were no transfers from these embryos. But anyway, again, they confirmed earlier thoughts, and that early events are important. I have to mention Marcos Mezleger's first paper. Again, we are 10 years back, where they confirmed the importance of the first couple of mitoses. Again, cytokinesis is supposed to be synchronized and fast. Interface supposed to be quiet and a long duration event. They also were checking multinucleation and confirmed that the multinucleation and uneven blastomer size, which again can change during the time, is a negative sign of embryo development. I'm jumping through these publications. There were quite a few groups that were, so to say, milking the time-lapse concept, and there are lots of publications that are coming out based on limited data from a single clinic, and many clinics were checking different attributes which may interfere into the course of the embryo kinetics. It can be like obesity, but does it change the kinetics or not? It can be the question of what type of culture media is used, does it change or not? And there were quite a few contradictory presentations and publications. Some said that it does not matter if what type of media is used. But some said that it does matter. The same was true for obesity and smoking. So there were quite a big hustle of what are those kinetic events which are important or not. So let's continue. kinetics is and the timings is an important thing, and it does give us some hint of embryo development. If certain events are way out of the reference value, then we can say that the embryo have a lower chance for a proper implantation. If they are right there in the reference ranges, then we can say that there's a higher chance for implantation. But time-lapse gives us a lot more information. One of these is the cleavage pattern itself. If you see the first image here, the cell is cleaving from 1 to 2 cells, and there's an interface. Again, this blastomer cleaves to 2, and this one cleaves to 2. Now we have a 4-cell stage embryo, and then the same pattern is being followed. This is like a normal course of embryonic development. If you transfer this embryo, you have a good chance for a proper biological function and a good implantation. But let's see. The first cleavage in the second row, it's proper. One of the blastomers cleaves to 2, that's fine. And this 3 is proper, it's okay. But here, this blastomer cleaves to 3. It's quite often happens. And this one is completely bad. So half of the embryo is good, half of it is bad. It's a mosaic embryo. It has an okay chance for pregnancy if this one's transferred. Look at this one down below. The first cleavage is going from 1 to 3 cells directly. It's a direct cleavage. It's a tripolar cleavage. And then doesn't matter what happens, it ends up in a completely abnormal embryo. And very importantly, this embryo can look beautifully. It can be a beautiful expanded blastocyst. It can produce nice pulsation. So this embryo can be beautiful morphologically, but if you transfer this embryo without appropriate testing, then that embryo may implant, but that will definitely abort. Fragmentation, we've been discussing it before. So the fragmentations are many times they are reabsorbed, and there's a high chance that without a time lapse you are going to miss those fragmentations. You're also checking blastocyst pulsation. Again, this is only possible with time lapse, right? So I've shown this image before. Blastocysts, they do collapse fast, and then they re-expand very, very slowly. With time lapse, we can automatically catch this rhythm, and if that rhythm is a proper rhythm like this, then it is a positive sign. But it can be a hectic rhythm. It can be a negative sign. So embryos that are pulsating with this type of pattern, it has a higher chance for pregnancy. Embryos that are pulsating with a hectic pattern, they have a lower chance for pregnancy. So what information can we get in the traditional time-lapse observations? We are getting information about the timings, about the cleavage pattern, about fragmentation, about pulsation. All of these are happening in a timely manner. Some have a resolution of like 1 hour, plus or minus, some have a resolution of a couple of minutes. So basically, if you want to get a proper information of the embryo's biological behavior, then you have a minimum capturing frequency of 10 minutes. Of course, there needs to be a proper device who does this without compromising embryo development. As remember, in the first couple of studies, they were using such a device which were only okay until the first couple of days, and then embryo development was compromised. So definitely, a proper device has to be used to get this information out from the embryo. So monitoring should carry 0 stress for the cells. So this was kind of like a fast introduction of the classical approach to time lapse. Most of the studies they discuss increased pregnancy rate, decreased abortion rate, and improved workflow. And we should not forget that time lapse is not just an embryo evaluation and selection tool, but it's excellent for quality control. It archives all the developmental stages, and all the images and movies are saved. And also, it's a marketing tool which might be important for the patients to get the first movie of the embryo who became their children after being born. So this is a fast introduction, and I would like to continue with AI. Can somebody give me a feedback if you see the AI presentation now?
I see the AI presentation. Presentations comes through, but it's pulsing like a blastocyst. Sometimes we see just a black screen, but then the images come up. I don't know what happens. You use Prezi, so probably when you switch screens, we lose it temporarily and we see it, but we can still follow you. So and now the second presentation came on.
Okay, but you haven't seen my family photos, right? So that was not presented.
Not yet.
Not yet. Okay. Okay, so what I was discussing, that is a classic approach to time lapse, and at that time, like 6 years ago, it was out of the question that the embryologist herself or himself should be taken out of the equation. So the time lapse was a true decision support tool, right? Where it gave information about direct cleavages, about the timings, about the timely change of morphology. And all of these gave an excellent background for the embryologist to decide properly without hurting the embryo, without taking them out from the incubator many times, what the biological competence of the embryo. I would like to continue with I think the most interesting topic in the IVF field today, which is the artificial intelligence and how it can be used for embryo prediction. The main topic of this talk would be embryo selection based on the combination of AI and time-lapse. I would like to start with talking about how AI is used for estimation of morphokinetic and morphological parameters in guided annotation. Guided annotation in the first, I don't know, decade or 8 years, it is the embryologist who had to do the annotations. Annotating 1 cell, 2 cell stage embryos, 4 cell, it's just easy. There's quite a low user variability. But if we go up until the 8 cell stage, or if I want to annotate the blastocyst stage, there's quite a nice variation in between embryologists. So how can a model be precise if there's a variation based on the one who is actually annotating the actual embryo? So if you go a bit deeper into how we score embryos using time-lapse, then this slide gives an overview of the current main options. We have the most used practice is the clinics today that embryologists manually annotate the number of morphokinetic and morphological parameters, which they think is important, or which is given by the model what they are using, and in this way they're evaluating the quality of the embryo. These are then used in an implantation model, like KIT score, for example. The model outputs a score for each embryo, and the embryos are ranked based on the score, which is provided by the implantation model. The first step is in automating this procedure is to use AI for predicting some of these parameters. So for the past few years, we were working on developing a number of AI-based algorithms. These algorithms, they automatically predict morphology and morphokinetics. The models are currently running in numerous clinics, but they have to optimize daily workflow. So basically, you don't need to decide whether the embryo is 4 cell stage or 3 cell stage. You don't need to scroll back and forth. The model using an AI automatically tells you that this is a 3 cell, this is a 4 cell stage embryo. And in 99% of the cases, it gives you the right estimation. So this is what we call an indirect AI method, because they still require an implantation model and are based on existing traditional parameters. So basically, I can explain it well to a fellow embryologist that this model is taking into consideration the T2, T3, T5 minus T3, and the time of blastulation, and the Gardner score at the end. And based on that, this is the prediction model, which is going to give you the final score. The AI here helps in the annotation itself. Another approach is the direct estimation. This AI approach directly predicts pregnancy, gestational sex, fetal heartbeat, or ultimately live birth. The only input for this is the time-lapse images. So yeah, I would like to go through an example of the indirect approach in which we have automated blastocyst grading using AI. And in case you are interested, you can find a lot more details in this publication. I can share at the end if you think it's important. Okay, so blastocyst grading. For the evaluating the method, we first train the AI on single images extracted at 110 hours post-insemination from the time-lapse video. Here we got an accuracy of around 60% for both ICM and trophectoderm. We then trained an AI on the whole video from 90 hours after insemination to the maximum size of the blastocyst. Here is an improvement to 65 and 70% accuracy, which means that there is indeed something to gain when using time-lapse videos instead of single images. And it does make sense. Because when we look at a single image for like 110 hours post-insemination, we may accidentally find a collapsed blastocyst like this one. I had this example in the previous presentation as well, right? But if we have a full sequence of images, we would see that just 10 minutes before, the blastocyst looked like this. And the AI will learn to utilize this kind of temporal information as well. Now, 70% accuracy is still way far from 100%, right? So, and the reason for this is that the grading of blastocyst morphology is really prone to both inter and inter-observer variation. For instance, here you can see two different blastocysts, on the left and the right, and they were each annotated by 46 different embryologists for both ICM and trophectoderm. On the left, you see that the vast majority of them agreed that it was a perfectly looking blastocyst with 8 cores for both ICM and trophectoderm. However, the example on the right seems much more difficult to grade. It's not that clear how it looks, right? So here we see that most of the embryologists rated the inner cell mass as B. A lot of them also said either A or C. So in this case, they disagreed quite a lot on both inner cell mass and trophectoderm. This illustrates how difficult the task is and why we will never get 100% accuracy when evaluating our AI and annotations from single embryologists. Therefore, we collected a small data set of 55 blastocysts and annotated by at least 5 different embryologists each. And this allowed us to calculate the average accuracy of an embryologist by comparing the answers of one embryologist against the remaining embryologists. And we did the same for our AI. We saw that it was actually a bit better than the average embryologist in predicting both ICM and TE. This means that embryologist spends time and needs to sit there at a certain time point. But the algorithm is not spending time. I mean, just works in the background and does at least as good as a good embryologist. So both the automated blastocyst grading and the morphokinetic estimation are integrated into our guided annotation tool. This is a tool which is running in one of the time-lapse devices. As you can see in this screenshot, all the different parameters have been estimated beforehand by AI. And in this case, some of the predictions are in bold. This means that the AI is more confident about these predictions than the others. So when on the graphical user interface, there is a tool which actually tells you directly that how confident the prediction for that embryo stage is. I know time is running, so let me jump. So going back to the overview from before, I have now covered some of the AI-based algorithms for indirectly predicting the chance of the pregnancy. However, the indirect methods are limited to traditional parameters and their predictiveness. They thus basically mimic current practices in the IVF labs. And so this was the indirect, when we understand the biological background. Now we go to the direct methods. They do not rely on an intermediate step of prediction of the traditional parameters. They use parameters which we can't really explain. They take the raw time-lapse image sequence and directly predict pregnancy, gestational sex, fetal heartbeat, live birth. Because of the improved workflow and consistency, we believe that the future of AI methods for embryo selection will be based on these direct predictions. Yeah, let me jump. For the rest of this talk, I would like to focus on the latest AI development for direct prediction of fetal heart. This model is called the IDA score. IDA means Intelligent Data Analysis for Embryo Evaluation. It's based on a technology which was developed by a group in Australia, and they used deep learning network, which we are developing further. It's based on it's a so-called 3-dimensional convolutional network. This implies that the network looks both at the appearance of a single image as well as the temporal development during the time-lapse sequence. Model was only trained on information about clinical outcome. Thus, the only input to the model is the image sequence, and the only output is the likelihood of a fetal heartbeat. The data used for the model development consists more than 100,000 embryos, of which more than 14,000 embryos were transferred embryos with either a positive or negative fetal heartbeat. Compared to the data set used for the training of this model, we have increased the size with a factor of 10. So there's quite a big numbers we are using for developing the AI algorithm. The data are coming from 18 clinics covering 3 continents and a lot of clinical practices. The number of embryos from each clinic range from around 500 to more than 24,000. In total, there are approximately the same amount of fresh and frozen transfers. The mean age per clinic is between 31 to 41, so quite a big range is covered by the data, which is the fundamental data for developing the AI. So this is used for the training. Based on the high quality data set, the model performance has to be evaluated. However, the measuring how a model performs is quite challenging task. I would not like to go into details now. So let's just jump a couple of slides. The ultimate tool to evaluate an output of an evaluation system is the AUC curve. This is what we are using as well. In this model, we have set aside 17,000 embryos out of the total 100,000 as a holdout set, test set. That is, the data set with the embryo was never seen by the AI during training. So if you train an AI system with a huge amount of embryos, then the AI system can predict with a great excellency of the embryos that the AI system was trained on. The true performance of an AI system would be tested if you use a completely independent set of embryos which have been never seen by the AI algorithm. So basically, based on that, we have established a model with an overall good performance, and let's look how this is generalized to a new clinic. So based on the donor clinic, so to say, we could achieve a very good prediction rate. So what happens if the same model is used to a clinic which is completely independent and those embryos have never been seen before? To evaluate this, we performed a clinic holdout test on 12 clinics that contributed with most data. Each clinic was evaluated with a unique model that was trained on the remaining clinics, but excluding the clinic that was to be tested, right? So thus the model has never seen data from those tested clinics. And here you can see that the model resulted in an EUC of more than 0.9, indicating a great generalization across the clinic. Of course, here as well as with the previous traditional approaches, we were checking the patient age, insemination method, incubation time, and basically none of these seem to have a significant deviating effect on the model. So AI model is often considered as a black box. You just put in the embryonic images, you program what the output is, what the output is connected to each of those images, and then it will come up with something, and you don't know based on what the AI is giving you a prediction. So there has been an increased focus, regardless of this, and increased focus and research on improving the understanding of how this AI system works. This is especially important when working with medical devices where decisions have a clinical impact. There exist 2 general approaches on trying to explain how an AI system works. Either you can try to understand each single decision, or you can try to understand the general behavior of the AI. We are focused on investigation of the overall behavior of the AI, and let me just go through this fast. This is done by investigating how the AI performs with regards to the already established parameter that we know that has something to do with implantation. One of the best known existing parameters are the Gardner grading score of the inner cell mass and the effect of them. that you all know that correlates with implantation, and has been the most used method of evaluating embryos, and still is. I think it is considered. So the chart here shows blastocysts in the test data set, which have annotations of the inner cell mass and dendrites. And on the y-axis, the average IDA score for each subgroup is shown. We clearly see that there is a significant decrease in the average score from the blastocyst labeled with an A compared to the blastocyst labeled with a C. So this trend is significant for both ICM and TE. So I mean, it gives us a confidence that this AI works correctly with this regard. Then we focus on the speed of development. This chart shows the average score for more than 2,500 embryos divided into categories based on the time to reach the blastocyst stage. To the left, there are fast embryos where the time to blastocyst is less than 100 hours. And to the right, we are slowly developing embryos where time to blastocyst are more than 115 hours. As expected, there's a significant decrease in the average IDA score with the longer time to blastocyst. Thus, the model has indirectly learned that the development speed is important. So again, it's very important. We did not teach the algorithm to look at that parameter. The algorithm actually realized it by being taught within the black box. So we don't know if IDA score actually learned that time to blastocyst, but it has learned that a fast development is much better than a slow development. Oops. My PPT crashed. So well, basically, I was almost at the end. I would like to conclude that based on more than 100,000 embryos, we could nicely develop an algorithm which is generalizable, which works independently of clinic, of culture system, and we are quite confident that the black box AI system has actually learned that knowledge, which is used by a proper embryologist when he or she decides if an embryo is good enough to be transferred. So with this, I would like to close this AI presentation, and I'm looking forward to getting your questions. Thank you so much.
Well, thank you very much for your presentations. This is probably a lot of new information for most of us. We have about 15 minutes to ask questions, and I probably will start asking questions, but if anyone else has questions, feel free to join in and interrupt us. So I actually will start with a question from Dr. Atta. We had a board meeting with the Hungarian IVF Society today because we in Hungary do not use PGTA yet, mostly because the regulatory bodies consider it experimental and they don't consider to have enough evidence in support of that. But we physicians would like to use PGTA, so hopefully we will be able to introduce it in the near future. But we need to introduce it in a smaller subset of patients where we can prove that the technology works, the logistics works, we can do the testing, and hopefully we can show that it results in good clinical outcome. So what would be your suggestion as a first step introduction, a smaller subset of patients where you would get started before you start expanding it to all other patients?
Thank you. Hungary is not alone. I mean, it's not allowed in Japan. The latest I talked to some French colleagues, France was discussing to, ban it, even if patients pay out of pocket. Okay, but it's not about the technology. It's not about the test. It's how it's being used, by the clinics. Okay, so people are concerned about, overuse, which does not justify the resources spent on it. Okay? But it obviously has some place. Okay, so to show an intervention is useful, a test is useful, you should work on a group, on a population that has the problem, right? So they should be old. I mean, not old, but I mean reproductive age-wise old. Okay, so if I mean the one of the limitations of this latest New England paper is they say they recruited until the age of 37, and given the mean and standard deviation values with the numbers they provided in the text, we did several Monte Carlo simulations. 95% of the patients are younger than 35. So euploid rate is already 55%. So, by random, you have a chance of picking up the euploid embryo 50%. Okay. So it is difficult for a test to provide benefit in that scenario. But I mean, if you work on women who are, the older they are, the more prevalent aneuploidy, older than 38, older than 40. Yes, you will detect aneuploidy. You may show it is preventing unnecessary stuff. I mean, if the study or if the assessment is designed in a way that to see if it improves, cumulative live birth rate or live birth rate, it will fail. It's simple. I mean, it doesn't fix the embryo. It just tests. Okay. So I think the best is just like Scott did. Okay, so if you can bring together a group of women who are older than 38 at least, and then do biopsy and blindfoldedly transfer the embryos, and then see how many of the euploids reach live birth and how many of the aneuploids that you transferred, without knowing, reach live birth. Yeah. If it is same as zero or less than 1%, as in Scott and Barat series, then it means your test is effective. You're preventing useless transfers and preventing miscarriages. That's the clinical way to see it.
And how would you address the issue of mosaicism? Should this be reported or shouldn't this be reported when you get the genetic test result?
I think firstly the name should be changed. Okay, it's not mosaicism. It is we observe a different copy number that's not consistent with euploidy, monosomy, or trisomy. Okay, there's obviously some test variation, and if 20% deviation, nobody reports anyways. Okay, so more than 20%, it is helpful in prioritizing. If you do really interpret the results properly, then I would like my genetics lab to tell me, listen, this embryo has 60% intermediate copy number, which is unlikely to be true mosaic. But I mean, there's something cooking, and as opposed to an euploid, it would have a lower priority, but I would still transfer it if there's not a better option. And let's say if that embryo with intermediate copy number has better expansion, better looking trophectoderm and inner cell mass, based on what this data, I may even prioritize it before an euploid with poor morphology. So the test does not categorize embryos as transferable or not transferable. It categorizes them as non-transferable, full chromosome aneuploidies, and then prioritizes for the rest. So for someone who has the understanding, I don't think it is correct to use the term mosaic at all. We don't test the cells one by one. It's an assumption, which is incorrect most of the time. And then I would prefer the detailed report to be able to properly prioritize my embryos.
Okay. Csaba, I have a question to you as well. Is there a patient volume in a clinic where you would recommend incorporating the time-lapse technology, especially with the AI, or is it a higher volume, smaller volume clinic, or that doesn't matter?
I don't think it matters.
Considering the price of the equipment.
I'm from research, so I don't really consider that part, but I don't think that matters. So I think genetic testing and time-lapse embryo evaluation, they go hand in hand. Time-lapse can give you a very nice estimate of the biological potential of the embryo to implant. Actually, it can perform the biological task which it should perform, and you have the genetic background what you can test. So I think the best estimate what you can get is PGTA plus time-lapse. I think that's supposed to be the standard everywhere.
So you think that the two should supplement each other? So you should use time-lapse to identify the good quality embryos or the embryos with a high chance of implantation, and then do the genetic testing on top of that?
Not as the rule of the thumb, but that I would select first based on biological competence, and if the history of the patient, and if the number of embryos are support that, then I would proceed with PGTA, right?
Are either of you aware of any results where time-lapse imaging, any kind of imaging or AI predicts euploidy? I'm sure that there are. You can put the embryos in a time-lapse incubator, then you can biopsy them, and then you can teach the AI system that this was a euploid and this was an uneuploid embryo. Is there any such data available?
That was the star presentation in the ESTE at Istanbul, I think. When in 2012, no, 12, yeah, 2012, that actually a prediction model can predict if an embryo is unemployed or euploid, and the key parameter, the golden parameter for that was the time of expansion and those timings at the blastocyst stage. But that wasn't really a generalized and a nice data set. So I don't think that time-lapse can tell you 100% if an embryo is unemployed or euploid. So that's a different testing method.
But there's no such research going on now, trying to figure out if you can teach the AI system to identify the euploid embryo.
Many things are being tested currently, but there were some earlier publications which showed an indication that time-lapse actually can show if an embryo is euploid or not, but that was not proved to be correct.
And is the IDA score is it available now, or is it just a research tool yet?
Again, I'm not in the commercial part at all, so we've been playing it and we've been testing it. Now there is a huge RCT going on with a couple of Australian clinics and a lot of clinics from the Nordic. So it has been tested in a proper RCT. I think it is out, but again, I'm not in that part.
Okay. And going back to Boris, so you say that the older patients would benefit the most, and if you look at the history of PGTA early on, advanced maternal age was one of the indications for it. And when you look at the RCTs, those patients were typically 35 or under with 7-8 blastocysts, so the really high responder patients. So you also mentioned that if you test a patient who an advanced maternal age patient, she has to be a high responder. So what percent of your over 38 population is like that? So what's a blastocyst number where you would say that it's worth to do the test? Because typically these patients will end up with 4, 5, 6 eggs. Will end up with 3, 4 embryos. They may have 2 blastocysts. Can you afford losing that blastocyst, or shouldn't you just transfer that blastocyst?
I am really a huge fan of individualized care. Okay, so you can't, I mean, we can't draw lines that sharp, right? So what I was trying to show is the older the patient, the more she'll benefit. The more eggs she has, the more she will benefit. But I mean, there's not a single number that excludes. Okay. So yes, it is rare to find someone who is 40 and generates 15 eggs. Right? So that's the ideal PGTA patient. But assume someone who is 42, 41, 75% of her embryos will be aneuploid, and she has 2 embryos, okay, or 1 embryo. So what I tell them is, listen, if you run the test and if the test shows it is abnormal, there's about 1% risk of discarding an embryo that could reach live birth. Right? On the other hand, if we don't screen, you have 75% risk that your embryo is aneuploid. Most of the time it won't implant, you won't lose much time. But almost 20% of the time, it may still implant. You may have, you may lose some time. And if you have miscarriage and if it's not early, okay, so there's some risk of evacuation, etc. And it's up to you. Okay, so depending on how we counsel them before and how much the costs are, okay? Assume PGT technology works fine and assume you're practicing in a setting, let's say like in Italy, okay, or in US. So a frozen embryo transfer cycle almost costs about $3,000. Okay? Monitoring, loss of work time, coming and going, then towing and transferring the embryo. And PGT itself costs much less than that. Whereas if you're working in Istanbul, where the embryo transfer is much cheaper than the test, then you may say, okay, I'll have the transfer and see what happens. So it's a subjective decision at the end. You can't, I don't think we can say, we can deny someone based on the number of embryos they have or based on their age. We can't tell anyone you have to do PGTA, and we can't tell anyone, no, you absolutely shouldn't.
You said that 20% of the unemployed embryos may implant. I thought that this was much lower. You referred to Richard Scott's studies previously, and I think in one of the in one of their papers, this was estimated to be around 4 or 5%.
It depends on the study again. Probably how they define unemployed. Yeah, it may be less than 20, but still, I guess it's more than 4 or 5. But anyway, so in any case, it's one thing. The decision for the older woman who has few eggs is really very difficult. Okay, so she's running against time. Time is precious. The embryo is precious. Then risk of with unemployed pregnancies is dire. So I just inform these people.
Okay. Well, we are approaching the end of this 90-minute session. I wonder if anyone from the audience has a question. Okay, well, if anyone has a question, then please speak up. I don't know how to raise the hand. There's this mark to raise the hand. If there are no questions, then I really would like to thank both of you for taking the time for giving us these presentations. I think that this is a lot for us to think about in the future, and you really taught us a lot. So I appreciate your time and the presentations. Thank you very much. And with this, I will close today's webinar then. Okay.
So much.
Just one sentence. I would like to say many thanks for the speakers and for the moderator. It was really wonderful, and I learned a lot. Thank you very much.
Okay, thank you and goodbye. See you in the future. Bye.
Bye-bye.
Thank you. Bye.